central incisor. And here we can see that's the line that we want. And if we draw this line, we can see that actually the lateral is a little bit too long, and so is the canine, because the lateral should be approximately 1 millimeter coronal to this red line, and the canine should be on par with this red line because it should be right at the same level as the central incisors. These are just basic principles that are obviously taught in the SPEAR facially generated treatment planning module. So here, if we go ahead and look at this, we can see that what we want, if we have a mirror image of this tooth, this is what we want our final restoration to look like. The gingival margins should ideally be more harmonious to the contralateral side if we want to restore this case. Otherwise, if you restore this case with those gingival margins on number 10 and 11, you're going to end up with an unaesthetic situation. So when you look at these cases, obviously take all of those principles of the facially generated treatment planning into account. Just don't jump into it by looking at one single gap that you need to replace. Now, if the patient declines this more comprehensive treatment, then that's another story, but at least you start off with the most ideal treatment and work your way then backwards from there. So in this case, we found out that we, in addition to being able to place the implant, and we'll look at the bony situation here in a second, which was kind of precarious, but we also needed some soft tissue grafting to at least cover these root recessions so that we can get better proportions of those final crowns, and then also to go ahead and bulk up that slight concavity there in site number 9 as well, if the bone would be good enough. Otherwise, bone grafting would be needed there as well. So here, when we move forward, the other aspect that we need to look at is that what we want with the implant planning is that we want our implant basically to be about 3 millimeters below that facial gingival margin. And you'll see during the surgical procedure how we go about by checking that and making sure that we indeed end up with the implant being 3 millimeters below the desired gingival margin, not what the gingival margin is right now. So if you can look, the gingival margin right now may be right here, but this is where we want to be, 3 millimeters basically apical to that, as you can see here in this kind of animation. All right, so here's the CT treatment planning in Galileo's. Once the CEREC optical scan and the optical design of the virtual restoration has been merged. And in this case, we actually fabricated, send this to CCAT for the fabrication of an optic guide. This can be done with a CEREC guide too nowadays. It can be done with a digital guide. It can be done with all sorts of guides. Probably this case would be the easiest to be done with a CEREC guide too these days. There's not much scatter, and you can certainly mail or print these guys in the office to do them yourself. Here you can see here the problem that we had, and I'll go to this a little bit more, was that we had this dilacerated root here, and then in addition we had this huge incisive canal. So we didn't have much room to squeeze an implant in here. This is actually a narrow 3.3 millimeter implant, but you can see that this narrow 3.3 millimeter implant is very close to the root in this aspect. And also, if you place it here for a screw retain restoration, we're going to have a facial fenestration here, which is not huge. We can definitely bone graft that, but this is certainly something to look at. So if we look at the close-up view here, after we planned this, this took a while to plan, but we ultimately ended up with some compromises. And one compromise, and you'll see this here more in close-up once we look at the surgical video, but one compromise was the fact that we are very close to the root here in the more apical area here. This is about 0.5 millimeter away from the root. I usually like to stay away from these roots by about 1 millimeter, but this was about 0.5 millimeter to this root. Now, thank God, or for our purposes, most importantly, we're away from the root here in the crestal area, which matters as far as the papilla goes, by about 1 millimeter, a little more than 1 millimeter. So this should ideally be 1.5 millimeters, which we didn't have here, but at least 1 millimeter. So here we're about 1.2 millimeters away from this adjacent root. But here more apically, we are very close to the root. And then also in squeezing this implant in here in the coronal aspect, we are very close to the kind of the insertion point of the incisive canal. Now this is okay because this will be a little bit exposed here, but we are right here, we are here right where the canal actually begins. So we're not impinging really on the neurovascular bundle, but we're very close here to the orifice of the canal. But by positioning the implant here buccolingually for it to emerge through the incisal edge, we can also avoid possible bone grafting here because we are at least 1.5 millimeters away here from the buccal plate. So a very tricky situation to plan, as you can see. Now, I would not plan this. Obviously, I could have gone more palatally and tilted this even a little bit more buccally to be even a little bit more here, but I did not want to come more facial to the incisal edge because then that would possibly cause some post-operative recession. So I always want to ensure that my restoration emerges right through the incisal edge. This is the surgical protocol that we received from CCAT. This is for the Straumann system, telling us what drills and what sleeves, keys to use. And then Dr. Scramstead then performed a pre-op scan before we even got started. And he, in these type of cases, he performed a virtual design for a 2-wing Maryland bridge. This is going to then act as our provisional restoration because since this was going to be a narrow diameter implant, we did not want to immediately temporize this implant because also you're going to do some connective tissue grafting as well. So there was a lot of surgery involved, and so we did not really want to temporize this implant. So here he fabricated preoperatively a Maryland bridge, and our goal was if we could place this implant flapless, because the way we planned it, we could avoid the bone grafting, then we could do a custom tissue former on this implant under this Maryland bridge and have this Maryland bridge still be in place. So this is the 2-wing Maryland bridge that Dr. Scramstead designed and ultimately milled. You can reinforce the connectors with ortho wire if you want. You have to relieve the ponic from the tissue surface by about 2 millimeters to 4 millimeters, depending on how much grafting is done. So if you're doing a lot of bone grafting, a lot of tissue release, then relieve it by 4 millimeters. If you're not doing that much, then relieve it by 1 to 2 millimeters. That should be adequate. All right, so then at this stage, I will just switch over and show you the surgical video of this case. Here, I just have to bring that up here. And let me go ahead and go to the full screen mode if I can. If this lets me. Well, sorry, this is a new system and this should let me do it, but I don't quite know why it's not. Letting me to go full screen. Oh, well. Okay, it might be because I made this mouse so large. There you go. All right, so here I'm going to restart the surgical video here. So this is the planning of the case. As you can see, we're very close to the orifice of the canal here. You can also scroll down here in the axial view, and this tells you how close you can come to the tooth and to the canal here in certain sections. So
Farhad,
yes?
I'm not seeing a video if there's one playing right now.
You're not seeing one?
No.
Huh, how is that possible? All right, hold on one second. You see one now?
No, can someone out there message me if they're seeing it, or it may just be me? There we go. Got it.
Okay. Sorry. I think what we should do, we should go back to the old system because here you have constantly to switch the screens and everything. So let me start from the beginning then. All right, guys. So here's the video, and thanks for hanging in there and letting me know. So everyone can see the video now, I assume? Okay, good. So at this stage, this is the planning. As you could see here, we are very close to the orifice of the canal here. Again, you can click here on the axial view and scroll down, and you can see how close you are to the actual tooth and the nerve. And then you can obviously always check in the 3D view. It's very, very important to always check any changes you make in the 3D view to make sure that you're on plan. So at the day of the surgery, this is the local anesthesia. Typically what I do, most of my patients are sedated, but if your patients are not, obviously this is a sensitive area to anesthetize. So I typically do some real minor injections, just barely under the mucosa with lidocaine. Let that sit for about 3 minutes to 4 minutes, and then come back and re-inject up higher in a stepwise fashion, just to not make the patient uncomfortable with Marcaine typically, to get a long-acting local anesthesia. If the patients are already sedated, then I may start with Marcaine right away and not go through that exercise. Here in this case, we also, just as pointed out, we wanted to do a connective tissue graft. So here I'm anesthetizing the greater palatal nerve here posteriorly as well, because we're going to harvest the connective tissue graft from the palate. Now, this is not something I'll show in this video. We'll talk about that in some subsequent videos on other cases, how to do that harvest. This was not part of this video presentation. Here we are just going into the incisive canal and anesthetizing the incisive neurovascular bundle in this area here after we have done the buccal, obviously, and then here a little bit more on the palatal side of this site. Again, just small injections. So the first step is, once we put this OptiGuide on, is to do a guided punch, which we can do with the Straumann guided punch. Here you can see it's fully guided. Most systems do have this guided punch, and obviously do that with copious irrigation. Make sure you go all the way to bone. Once you do that, many people have contacted me and said that after they do this punch, they get a lot of tissue tags when they remove this. So what you have to do then is, before you try to remove that punch, just go ahead with a sharp blade. Usually I use a 15C and just trace that outline of that punch very carefully, especially when you're doing it here in the anterior area. You'll have a lot of tissue tags. In this case, as you know, we're very close to the incisive neurovascular bundle in that orifice. So you're going to excise some of those fibers as well. So there will be a lot of tissue tags here. So just take your time and go ahead and basically really outline this very well to the bone. You can see here we go around multiple times. May look like we do it too much, but it really is important to make sure that you get a good, solid, basically clean incision all the way to the bone, and you won't always get that with the punch. So once you have done this and you have basically made the outline, then we take usually a mold curette. You can take a Lucas curette as well. I usually prefer a mold. And then with the mold curette, I go in and then do almost like a periosteal elevation to try to get that off of the bone as clean as possible. So my goal is not to have any tissue tags hanging in there, but that's why I kind of edited this so that you can see more of it. But this is something that we take a little bit of time doing so we can get a really clean punch out. And obviously you only do the punch when you have enough bone and when you have enough keratinized tissue, such as a case like this. Now here, as you can see, we have got that buccal concavity, but remember, we're going to do a connective tissue graft there, so we can still do a punch and do a tunneling underneath there to do a connective tissue graft, which you will see done later on, or you'll see the finished product. So here's the punch tag that's been taken out. Then you can go around with your curette and curette a little bit more any residual tissue tag, so you have a very clean bone surface. All right, so once you do that, then you can go ahead and basically put your guide back on. And here's the guide back on. You can see it's been stabilized here with a bite block. And then this is the initial key for the Straumann 2.2 drill. And at this point, you just follow the protocol here. Once you do this, just make sure that you don't do it fast. Just go in with pumping motions in and out. And that way you can get water as a coolant down into your osteotomy. Also important, once you do this, between every osteotomy, go ahead, either yourself or your assistant, make sure you rinse that osteotomy out with your chilled saline solution. So just don't go one drill after the other and try to rush it, because I've gotten a lot of cases as second opinions where people have really burned the bone because of guided surgery. But if you go between each osteotomy and rinse the site out really well, you can even remove the guide if you want. Take your time, you're in no rush. And you do that, then you will not get into those situations. Here's the second drill. In this case, it's the final drill, because with the Straumann 3.3, you drill only up to the 2.8 millimeter drill. So this is the final drill, again, going up and down in a pumping motion. Now, once we have done this and taken this out and we rinse the site out, now we could theoretically go ahead and place the implant. But at this stage, it's important in anterior cases to do a measurement. You can see here we have planned everything, obviously, in the CT scan, how deep to place the implant, but a lot of times, especially in anterior cases, you have to make some modifications. You can see here our punch goes all the way up to here, but right there where the probe is. But if I go ahead and put the probe exactly at the gingival margin of the contralateral central, you can see and mark it, kind of press on it, you can see we have a line here, right here. And from this line to basically our current gingival margin, it's about probably 1.5 to 2 millimeters, as you can see in this measurement. So that needs to be taken into account, how deep you place your implant. So you can see now I have switched to a regular Straumann drill on a Verben drill stop so that I can still drill guided a little bit deeper. Now you can do this freehand as well. Since I have the Verben drill stops for the Straumann system, I just like to do this guided as well. So here's the Verben drill stop on this non-guided Straumann drill this time to just drill a little bit deeper so that we can get the implant deeper according to where it needs to be, namely 3 millimeters below the future gingival margin. So again, this is something you really have to pay attention to, and just don't go with your guide planning, but do a measurement with a depth gauge in between. Again, here's the Verben drill stop going all the way down here. Obviously, those are measurements that you do as well. Then just make sure that now when you place your depth gauge, you can see that now we go in deeper, and now we're actually at the right depth if you do the measurements, that you're 3 millimeters below that line from that contralateral central. Now, sometimes those Straumann depth gauges have got that round top on them, so you can use some depth gauges from Straumann that don't have that round top on them to measure it if you're doing it flapless. Now, some people have also asked me when it's important to do this profiling of the bone. This is before implant placement, so this is bone profiling before the implant placement. I do it on almost every single case. If the bone is really soft, I may not go in all the way, but this uses a different handle. This uses a C handle where you put the handle onto the drill and then place the whole complex onto the guide. The Straumann users are familiar with this. This is the way this specific profile drill is inserted. So you put it first there, and then you put the whole complex on, and then you drill. In this case, I went all the way to depth because this was pretty cortical site, especially coronally. So I like to profile the bone before placing the implant. I always use this. Now in softer bone, I may not go all the way to the hub. I may stay about 1 millimeter or 1.5 millimeters short, but most of the time, if it's a little denser bone or medium dense bone, then I go all the way to depth, as you can see here. And you can see the bone that's been basically harvested with this profiling. Now, if you don't do this, then you may put too much pressure on that thinner cortical bone, and then that cortical bone can then resorb. Here's the Straumann implant. This is a rock solid zirconia alloy, titanium and zirconia alloy implant. This is a 14 millimeter length in this case with a 3.3 millimeter diameter. These don't come with the guided mounts. If you use those guided mounts, they come with the regular locks and mounts. So there are a couple of different ways to put these in fully guided still. You can do what I did here initially. Right now, you can put on a regular mount and just put this, take this out of its ampule and put it through the guide. Initially, this is obviously non-guided at this point. You can see here, this is just placed into the osteotomy just slightly through the guide. And but this is obviously right now, there's no guidance of that implant placement. So I just turn it in a couple of turns so that it just stabilizes in the osteotomy. And at this point, then we can take this non-guided locks and mount off and go ahead and put a guided mount on. If you do order the guided implants, they come pre-mounted with a guided mount, and you can keep those mounts and reuse them for future surgeries, such as we did in this case. Or there's a new mount driver that makes this actually easier, so you don't even have to buy those guided mounts anymore. This is a guided mount that we kept from some old surgery, re-sterilized it, and now we can take the non-guided mount off. Here you can see here, this is the non-guided locks and mount. We can just kind of take that off. The implant is semi-stabilized in the osteotomy, so just stabilize it enough so that you don't pull it out as you're changing these mounts. So here we pull that out, and now we can go ahead and this is the locks and mount, and now we can go ahead and put the guided mount on, which then fully guides this. So this is one way to do it. You don't need to do this anymore really, because now Straumann has come out with a guided mount that really fits that really well. So you can still use the lock-in mount and use the guided mount driver, and that works extremely well. That was not available when we did this specific surgery. So here you can see this is the guided mount, and now we just simply put the driver on it. And I usually like to use the hand ratchet and not necessarily use the motor driver. A lot of people like to use the handpiece driver. That's totally fine. That's totally preference. My preference is just to use the hand ratchet. I feel like I have a little bit more control doing it that way. So here you can see now we're kind of just slowly turning this into place. Now we'll speed this up in the video here shortly, so don't think that we always go at that speed, but we just simply go at a relatively low speed, and this is now fully guided as we're putting it in. Obviously, we also see that this guided mount has got these markings on it. The new drivers that fit on the lock seam have these markings on them too. That corresponds to the heights that come in your drilling protocol. So what happens is that in your drilling protocol, you can see here that's H2, H4, and H6. And in this case, it was H6. So we go to that depth, but remember, we drill deeper. So then we have to then either take the guide off and put the implant deeper, or use a different type of mount through the guide to place the implant deeper to depth. So here we are just ratcheting this in, obviously not this fast. This is just sped up for the video. But here you can see we go all the way with this guided mount all the way down to that H6 marking. And once we have reached that, then we know that we have put the implant, but it's not 100% to depth. So now we switch to this non-guided mount again, which is thinner, and now we can go in deeper. The nice thing is that these have got markings on them too, 1, 2, 3. So you can see how deep you place your implant, so you can judge the implant placement depths that way as well. So we go ahead and put our guide back on, and the new mounts, the new drivers that are available, they fit like this. This is an old one, but they fit exactly like this into the master sleeve, so that you don't have to use those guided mounts like I just showed you anymore. And those have the markings on them as well. So you can go ahead, we can see that we are ratcheting in this implant again deeper to full depth, because remember, we drilled deeper than what the protocol that we had originally planned, because there are always discrepancies, especially in anterior areas as far as depth goes when you plan them in the CT scan. So always double check during surgery. Sometimes you may get it right according to your plan, but sometimes you don't. Now the guided mount drivers, those lock-in mounts just pull out. The guided mount drivers, which we really are not going to use anymore, those have to be held in place with a key and then just unmounted by ratcheting them out in a counter direction. You don't have to do that anymore, because none of you will be really using those guided mount drivers anymore. Now we've got those guided drivers that you can order separately, or they come as part of the new guided kits, and then you can use the lock-in mounts that are then much easier to use. This is the old one where you just had to really pull this guided mounts off. Now at this stage, once the guided mount is off, obviously as previously stated in our plan, we wanted to go ahead and place a custom tissue former here that we would do with a CEREC. Now, one of the things that if your implant does not achieve enough primary stability, please do not try to put a custom tissue former on it. Just put a smaller healing cap and let it heal undisturbed. But if it does reach enough stability, you can either temporize it immediately, or if you don't want to temporize it immediately, such as in this case, because this was a narrow diameter implant and we were doing some connective tissue grafting too, then you can go ahead and basically do a custom tissue former. This is just the removal of that guided mount. And here you can see we have placed the bone profiling pin, and this is the guided bone profiler after the implant is in place. And what I like to do is that I like to not use the biggest size initially. In this case, because this is an anterior case, we would use a size 2. An anterior, if it was a lateral, just a size 1. So this is just a size 1 initially, because I want to see how the size 1 and 2 make sure that they don't remove any papilla. And then now this is the size 2 that is placed. So I check that to make sure that I'm not removing too much tissue by just going to the size 2 immediately. And you can see here, this is a very careful check. Once I verify that, now I can go ahead and basically do the profiling with the size 2. Size 3 is something that you don't do in the anteriors. That's only for posterior molars. And if this was a lateral, I would just stop at size 1. So you can see this is size 2, profiling the bone and the tissue here in a very guided fashion. You can see here sometimes you've got little tissue tags that you can then either just pull out with a pair of tweezers or just use a little blade to then remove those little tissue tags if they do remain after this profiling. So here you can see this is the little blade that's used just to kind of remove that little tissue tag, and nothing major here. And then at this point, then you can go ahead and remove this little direction indicator pin. It's important to put a piece of gauze so that it doesn't fall down here and the patient aspirates it or it goes down the patient's throat. So always just use those safety or security measures. Also, typically, as you can see here, I typically put my finger behind it. That's why you can't see it here, behind that pin, so that once I unscrew it, I don't unintentionally drop it, because especially after we use these couple of times, they will sometimes drop out of that driver. So very carefully take it out so you don't drop it. So here's the case after it's been profiled. Now Dr. Scramson has already done his preoperative scans, and you should have done this preoperatively as well. So when you put a scan post in this case, all you need to do is go ahead and just scan the head of the scan post really, and then do a cut and merge. Now that is, from what I've gathered, a little bit of an issue right now in the new 4.5 software. It works sometimes and sometimes it doesn't. But that's a technique that we all have learned from Mike and Sam and Mark, in that you go ahead and place your scan post, just scan this, and then obviously you have your pre-op gingival mass scan, and you can just cut that portion out. So this is just a quick, really, that takes only 10 seconds to only scan that scan post and scan body complex. You don't need to do the whole scan because you have already done that preoperatively in your arch folder or your gingival mass scan folder, obviously. So here it is. Here is Mike just scanning that scan post. And then based on that, he fabricated a custom tissue former. This is something that obviously we have talked about and shown in our courses and videos as well. You can see here in the meantime, while Mike was fabricating this custom tissue former, I went ahead and did a connective tissue graft here on this lateral and canine, and also tunneled underneath here. Now I sutured all of this except this area right in here, because I wanted to make sure to leave enough space so we can insert this custom tissue former. So here's the custom tissue former as it goes in. This is very nicely designed by Mike. This is very easy to do. The best material to use is enamic for this. It mills quickly, and you can mill an abutment and just cut the chimney off. After that is done, the custom tissue former is in place and is hand tightened. Now we go ahead and we just basically do that last suture there for that distal papilla on number 9 over that connective tissue graft. You can see here the edge of the connective tissue graft. It extends here from number 9 facially underneath the tunnel here all the way to number 11 back here. And this is where it came from, if you can see it here in the palate. So here's the suture, just that one papilla, and now we've got here our custom tissue former. All right, so this is the surgical video. So let me now go back, if I can, to that presentation. And all right, so now we basically, this is the situation. This is where basically our graft came from. It was a quite large graft, obviously, going all the way from the mesial of this premolar distal of the canine all the way to number 9. Custom tissue former.
We're still on the video there. You need to minimize that.
Oh, it switched again. Okay, hold on one second. Okay, now.
There you go.
Okay. So here you can see the situation right after the surgery. You can see the connective tissue graft here. Sorry, you can see the connective tissue graft. This is where it came from in the palate, and it extends all the way here from number 11 to number 10 to the facial of number 9 underneath the tunnel here. That's the connective tissue graft. This is the custom tissue former that Mike fabricated based on those CEREC scans. And then we put Fermit, or we put some Teflon tape and a little composite. Usually I like to use Telio here so that it can be removed very easily afterwards to seal this off. So once this is done, now the surgical portion is finished. Now, obviously, we had, before the surgery, we had prefabricated the Maryland bridge. Here's the post-operative CT scans. I actually had Mike, after the initial insertion when we took this x-ray, I had him reduce this even a little bit more because I thought that this was impinging a little bit too close on this bone. So you can see here, we reshaped this even more. Now, obviously, these tie bases were still wide. You can see these have been reduced. The new Straumann tie bases or vario bases for CEREC, they're going to be called Vario Base C, which will be hopefully FDA approved soon. They will have a much narrower platform to where they come up higher. They go like that, so you don't need to do this manual reduction anymore. But you should try to get this away from here as much as possible, by at least 0.5 millimeter as shown here in this specific situation. And here's the Maryland bridge that Mike had prefabricated, pre-milled preoperatively. Here's the Maryland bridge, and it just goes on top of that area and just gets kind of bonded into place, sitting right on top of that custom tissue former, and thereby we're still providing the patient with a fixed restoration. Here it is in the palatal view. You can see it here, bonded in place, and here it is right after the procedure. Here, this is actually, I think this is at a 1 week post-op appointment. So here it is, the close-up view at the 1 week post-op. This is the connective tissue graft. So this is actually right after surgery, sorry. And this is the Maryland bridge that was then bonded in place, taken slightly out of occlusion, obviously, so it doesn't get knocked loose. And then after about a period of 2 months, that's all we need to wait. If the implant does have good primary stability, then Dr. Kevin Kvechen, the resident prosthodontist at Spear, one of them, went ahead and temporized this implant with a provisional. This was the first provisional to start to condition the soft tissues here. And you can see, by the way, when we go back, you can see nicely how the root coverage that we achieve with the connective tissue grafting here, to be able to put these at the same level as the contralateral teeth, and also to bulk this up with the connective tissue graft. Now we can go ahead and we see this. The patient didn't have real good oral hygiene, so his oral hygiene lacked, but then Dr. Kvechen started developing this even more to where, with the provisional, to push this gingival margin out to exactly the same level as the contralateral tooth. Here you can see the nice development with the custom tissue former and then with the subsequent provisional. Here you can see here he's drawing lines here to add more contour to the provisional here to start pushing on this gingival margin. You can see the blanching here so that it's on par with this contralateral central, and eventually he achieved that. So now we've got good symmetry before then he went to the final. I saw this patient back after about 6 months, I think, for a post-op CT scan. You can see here the post-op CT scan once we merged it with the pre-op plan, how accurate we were in our placement here. We have good facial bone, and we placed the implant exactly as we had planned it. Here's the close-up view. You can see here we are away from these roots here, obviously relatively close here in the apical area, and again, very close to the orifice of the canal here coronally. But these are compromises that I was willing to take to be able to do this case in one step. The buccal plate is nicely maintained. And then this is the, I think these are the finals, or this may still be a set of provisionals. I think these are a set of provisionals that when done on all of these 6 of these teeth, trying to develop the tissues even more. And here it is. And then here's the patient in his current set of last provisionals until before he goes to the final. So I hope this has been informative, and I'll turn this over to Dr. Fleming. I know we ran a little bit late because of the technical difficulties, but if you have any questions, please feel free to ask him at this point, or you can also post them to the boards, obviously.
All right. Thank you very much, Farhad. We'll get things worked out here. This is the first time here for tonight. Like Farhad said, if you have any questions, place them on the boards. Otherwise, we'll see you all next week. Thanks, Farhad.
Thank you, everyone.